So welcome to this dialogue on SGLT2 inhibitors in heart failure. We have the privilege to have as a guest today Javed Butler. Thank you very much, Javed, for accepting to be our guest today. It's a real pleasure. Very briefly, Javed is president at Baylor Scott and White Research Institute and is professor of medicine at the University of Mississippi Medical Center. He got his early education in Karachi, Pakistan, where he got also his bachelor, and then he had a Master of Public Health at the Harvard School of Medicine and an MBA at the Emory University. Javed has a long track in the field of heart failure and has contributed to major studies and discoveries in this area, particularly in the management of therapeutic management of heart failure. So we have an expert today. You can ask questions. I hope that the contribution of the participants will be very active, and you can either ask the question or write the question, but please, before asking the questions, make sure your microphone is on and you're watching the camera. The participants to the dialogue today are also Shelley Zieroth from University of Manitoba in Canada. Shelley is professor of medicine, is an expert of the heart failure, and she's an editor of the European Heart Journal, as well as Carlo Patrono and Giovanna Liuzzo will join us in discussion. Hi, Shelley, Carlo, and Giovanna. Good to have you on board today, and they will help us in making the questions. And let me say hello to our editor-in-chief, Filippo Crea, who is also joining us. I see that we have already a good crowd. So my first question to Javed is a personal question. So Javed, can you very briefly describe your roadmap across medicine and towards cardiology and heart failure, where you started and where you think you are today?
Great. So first, thank you very much for the opportunity to talk to you all. I really appreciate talking with you all. So I have jumped around quite a bit in my career. So I, as you mentioned, went to medical school at the Aga Khan University in Karachi, Pakistan. Then I landed in Connecticut. I had come there as a medical student to do some electives and do some research, but ended up doing my residency there and a year of chief residency. So that was sort of 4 years there. Then came to the south of United States at Vanderbilt and did cardiology fellowship there, and then a year of heart failure transplant, and also went to Mass General for a year to do cardiac imaging training. So did those two subspecialization training. And somewhere in the mix, got interested in some other things as well, statistics and research. So that led to doing a master's in public health at the Harvard School of Public Health, and then did an MBA from Emory. So was a junior faculty at Vanderbilt, sort of rose through the ranks, became the director of the heart and the heart-lung transplant program. Then ended up getting married to somebody from New York. She really didn't like Nashville, so that led to moving to Atlanta, a bigger city, was at Emory, then became chief of cardiology and head of the cardiovascular service line at Stony Brook University, and then moved to University of Mississippi, where I was chairman of the Department of Medicine. And about 6 months ago or so, I took a corporate role at a large healthcare system in the US called Baylor Scott and White, where I'm senior vice president for the health system and president of the research institute. So lots of jumping around.
Okay, yeah, you're a globetrotter, like a basketball player. But we want to talk about heart failure today. So my first question is, we're focusing today on SGLT2 inhibitors, this surprise in the field of heart failure coming up by serendipity from all the studies on anti-diabetic drugs, recommended by FDA after the first initial studies with other compounds producing more heart failure. So one of the questions that I hear around very frequently is, how do they work? And I know that this is a difficult question, but your point of view is very important. So what do you think?
Yeah, so, all of our thought processes has evolved. It really reminds me of Karl Popper, that all science is provisional and works by falsification and not by proving. And provisional meaning what we know today is what we know, and we change our mind in the future. And it works by falsification because you can only disprove hypotheses. It's really difficult to prove anything in science. So I had a somewhat of a, simplistic view that, they have these effects on the heart and on the kidney, on the vasculature, probably related to decreased adiposity, inflammation, oxidative stress. And that's how sort of, it works. So I'm in this phase of my career that I have the pleasure of working at the same institution with a colleague of mine who I attribute everything in terms of my choosing heart failure to begin with, and that's Milton Packer. And being in the same institution, I have this luxury of going out for dinner with him about once a month. And he kept on telling me that, he feels that these drugs work through mechanism that has nothing to do with SGLT2 receptor. So I'm like, come on, Milton. I mean, these are SGLT2 inhibitors. Like, what do you mean that it's nothing to do with that? And he had this notion that these drugs work through basically three mechanisms at the cellular level, at the heart level, irrespective of the SGLT2 receptor per se, because remember, SGLT2 receptors are not expressed in the heart. And at least my pushback to Milton was that that's normal physiology. But we do know that in pathophysiology, the receptor densities in the heart changes. So maybe, there is something more there. At any rate, so his hypothesis was that one, there is increase of sort of nutrients going into the cell in a heart failure state, but they're not utilized. And then you have all these toxic byproducts. So nutrient deprivation signaling is affected. Then secondarily, there is mitochondrial dysfunction. And then third, he sort of had a really, really novel hypothesis, and that is related to improved intracellular iron utilization. So then we did the EMPEROR studies, and we had access to blood. So Fayez Zanad published this paper in actually European Heart Journal looking at the proteomics. And sure enough, some of the proteins that are modulated are all related to autophagy. So I still did not give full credit to Milton, but this week in Circulation, there is a paper with SGLT2 knockout mouse model. And the benefit of SGLT2 at the cellular level in this post-infarct mouse model in SGLT2 knockout animals is exactly the same with empagliflozin than the wild type. So I would end by saying that, yes, human biology is complex. Yes, these systemic effects are there, but probably there are these cellular effects which are directly related irrespective of the SGLT2 receptor.
Thank you very much. Well, we have Shelley Zieroth today. She's a top-level scientist in the field of heart failure. I'm sure Shelley has very good questions for you today. I had the honor to collaborate with you on some ideas in the past, and so I know very well that you are connected. But Shelley will make tough question, I'm sure.
Thank you, Massimo. So first question, Javed, personal one. How is your new family member?
Yes, so new family member is doing well. We have 3 cats and 2 children, and that wasn't enough. So now we have a dog. So right now we are trying to just make sure that there's peace in the house between cats and dogs, but it's working out okay.
Wonderful. It's such a cute dog. So I want to ask you, we recently published with the European Heart Journal supplement, a dedicated HFrEF issue. And one of the articles which you were part of was, does ejection fraction matter anymore? Seeing as though we have strong data across a continuum of ejection fraction with SGLT2 inhibitor therapeutic use, does ejection fraction matter? And we also did publish in the European Heart Journal the emperor-reduced, emperor-preserved meta-analysis. And then there was this group with an ejection fraction greater than 65%. Does that matter?
Yeah, so I mean, I would say that today we know a whole lot more than what we did 50 years ago, and 50 years from now we will know a lot more then. So where we are today, I can understand the reason for this controversy, because our knowledge base is somewhat limited, and we are understanding this. So today, I would say the ejection fraction sort of definitely matters, right? Because if you look at heart failure therapies that are primarily targeting neurohormonal modulation, ACE inhibitor, ARBs, ARNI, beta blockers, MRA, those therapies tend to work primarily in patients with low EF. And what is low EF is also up for debate, right? There are differences between men and women because of the size of their heart. It's dependent on afterload, preload. But I would be comfortable saying that anything less than 60%, you're likely to benefit from those therapies. More than 60%. So far, we really haven't proven. Whereas with SGLT2 inhibitors that don't primarily work through neurohormonal modulation tend to work across the spectrum of ejection fraction. So ejection fraction today works for practical reasons, because that's how we have done trials, for practical reasons, because device-based therapy is really linked to ejection fraction as well. So it does matter. Now, in the future, whether things will change, we are really living through the most incredible time in medicine with all the omics revolution. So understanding the biology is at an unprecedented pace. So in the future, maybe we will define more with biologic pathways as opposed to this crude manifestation per se. Now, you asked that question about, do SGLT2 inhibitors work above ejection fraction of 60 or 65%, and that sort of comes from this earlier data from empagliflozin that there seems to be some attenuation over 65. But what we miss is that that attenuation above 65 is only really limited to between EF of 65 to 70, and over 70, there seems to be even more benefit. And then when DELIVER trial came out, they saw absolutely no heterogeneity. So it's either a chance finding. When you do too many subgroup analyses, you find these sort of unusual correlations, or we don't totally realize this issue of, how many undiagnosed hypertrophic cardiomyopathy or amyloid patients might have been represented in some subgroups. So we'll learn more. But if you look at the totality of evidence, it seems like it works across the spectrum of ejection fraction.
Carlo, we had the chance to discuss together several times, the pharmacological aspect, but also the implication of the clinical trials. What is your, main question that you want to put to Javed tonight?
Well, going back to the issue of mechanism of action, I was quite intrigued by your topic review of the week in JACC last year, where you discussed the potential use of these agents in patients with acute myocardial infarction. And you mentioned 2 ongoing trials. And looking at the primary endpoint of these trials, which are essentially time to first HF, hospitalization or death, it looks like you are moving backwards in terms of the natural history of heart failure, like a sort of primary prevention. But in the same article, you outlined the possible existence of direct cardioprotective effects of these agents, like the mechanism you refer to as suggested by Milton. So what is your idea behind testing SGLT2 inhibitors in the setting of an acute myocardial infarction? Are you looking for primary prevention of heart failure, or are you looking for additional cardioprotective effects?
Yeah, so thank you. I mean, this is a really important question, and both the trials have had sort of some people push back, saying that listen, I mean, you have all of these benefits shown in patients with heart failure, including those with ischemic etiology, and do we really need to do a trial in post-MI patients? Should we just not give it? And if you look at the drug development history in our field, all of these drugs, whether it's ACE inhibitors, whether it's beta blockers, MRA, you have done sort of separate trials in severe heart failure, mild to moderate heart failure, and post-MI patients. And many times it has worked out. We unfortunately had a negative trial with ARNI, with Paradise MI, did not reach its primary endpoint. And the reason why this question becomes important, one is for the reasons that you mentioned, giving it upstream and make sure that you can get benefit. We do know that you have prevention in 2 high-risk subgroups of new onset heart failure with SGLT2 inhibitor. So type 2 diabetic patients with either known atherosclerotic cardiovascular disease or high risk. So that's been very well proven. Not necessarily as deep a database just quite yet, but nevertheless, there are data with CKD patients, even in non-diabetic CKD patients. So at least in those 2 subgroups. But in post-MI, we really need that information, and we can't assume, the last real sort of advance in terms of the pharmacotherapy for post-MI risk modulation is now good, 10, 15 years ago. And the phenotype of heart failure post-MI has also evolved from predominantly systolic to predominantly now HFpEF as well. The other issue is that we all completely believe that SGLT2 inhibitors not only preserve renal function and are good for renal function in the long run. We used to say that acute kidney injury is a risk. But if you look at the recent Lancet meta-analysis, there's actually a 20% reduction in even the investigator-reported acute kidney injury. So it's not only the long-term but acute kidney injury. But in acute MI setting, you are potentially giving a new RAS inhibitor, a new MRA. People just got IV contrast for their cath. They're getting procedures, maybe some changes in blood pressure, and right with that cocktail, you're also starting an SGLT2 inhibitor as well, and trying to start really upstream. So I think for both safety and efficacy, whether you can prevent one of the worst complications of MI, which is new onset heart failure, these trials are really needed, and hopefully we'll get the answer soon.
Before I go to the audience and to our colleagues, be ready with your questions. I wish to ask Giovanna, who's an editor of the European Heart Journal and a very active member of the weekly journal Scan. Giovanna, what do you prepare for Javed today?
First, I would like to continue the question of Carlo about the acute MI patients. And I was wondering also from the answer of our guest about the opportunity to start very early these drugs. And what do you suggest to clinicians to start these drugs in any patient in the post-MI or in a special subset? As you said, we have a patient at 5 days after an acute MI that are already with a lot of drugs on top. So what do you suggest us to start also a gliflozin or not?
Yeah, so a little bit of a nuanced answer, right? So early post-MI, that's the question that we are studying in the trial. So there are 2 trials going on, IMPACT-MI with empagliflozin and DAPA-MI with dapagliflozin. Very minor differences between the 2. We're looking at both type 1 STEMI and non-STEMI MI. DAPA is in the first 10 days, EMPA is within the first 14 days. And there are some enrichment factors. So we will get the answer to the question. Now, if you had an acute MI patient with a drop in LV ejection fraction, the question is this stunned myocardium, will it come back up, or is this permanent heart failure that has been developed in post-MI patient? In the first case, that's what we are studying right now in the trial. So I would not necessarily recommend just quite yet to give it upfront till we get the results of the trials come out. However, if somebody post-MI has dropped their EF and you follow them up and in a month later, the EF is still low and basically they have post-MI heart failure, that's basically your ischemic cardiomyopathy patient. And I think giving an SGLT2 inhibitor would be very reasonable in that person.
Okay. So if I can, just another question in the same line. Do you think that there are subsets of patients that can have more, collateral effects than others? There are patient in which we need to be more to have more caution in the use of these drugs, or we can go ahead, without any problem?
Yeah, so the reasons where we sort of run into trouble with these heart failure medications are sort of all the usual things, right? So heart rate, blood pressure, potassium, creatinine, and at least so far in the heart failure trials, those have really not been an issue, and patients have tolerated. Now, of course, it's just not a good idea to take mean average results from 4,000 or 5,000 patients trials and implement it to the patient sitting in front of you, and we will always individualize it. And if you're an older person with orthostatic symptoms, maybe cutting down the dose of diuretic, or you're using lower doses. I mean, those sort of personalizations we will always do. But by and large, on average, none of the reasons for which other guideline-derived medical therapies have been a little bit of a problem has turned out to be an issue with SGLT2 inhibitors. But I would again caution us that immediate post-MI period, the vulnerabilities might be different than in the chronic heart failure setting. And I think just waiting for these results to come out, I think will really guide us in a much more evidence-based way.
Javed, can I just add just one component to that in the acute heart failure clinical trials, that there were clearly hemodynamic stability criteria that had to be met, including blood pressure and lack of vasodilators. So it was a very select patient population. Stability criteria existed. And something that I've learned from my diabetologist friends is that it's also important to identify people who are metabolically stable. So avoiding use of these drugs in patients who have really high hemoglobin A1Cs and very high insulin requirements. You definitely want to engage with an endocrinologist before considering in that patient population.
So there are criteria that we need to follow, because there are subsets of patients in which we need to be more careful than in others. So it's not like, as for with the ARNIs, we are very careful regarding blood pressure. With these drugs, we also should to be careful in some subset. Can you agree with this definition or not?
Yeah, no, 100% that, we have to be cautious. Now, ARNIs tend to have more effect on blood pressure. Again, the average, and I'm very cautious about not implementing averages on every patient, but in Emperor Reduced, the reduction in blood pressure was 1.2 mmHg, and in Emperor Preserve was about 0.7. So the overall impact of SGLT2 on blood pressure is lower. But to Shelley's point, while we don't have the acute MI data, we do have trial in acute heart failure. But you could use it while somebody's on an IV diuretic still and is being decongested. That's not a problem. But nevertheless, not in the emergency room. You've been in the hospital at least for 24 hours. You're not requiring IV inotropes, not requiring IV vasodilators. And another point that Shelley made is really nuanced and important. And that is, there are people with really high hemoglobin A1C who might actually benefit from an SGLT2 inhibitor added not only for their cardiorenal issues, but also for metabolic issues. But the nuance here is your very high hemoglobin A1C just poorly controlled diabetes, or are you now transitioning from a type 2 to almost like a burned out pancreas physiology, and you're requiring high doses of insulin? And one of the biggest indicators there is lean diabetic. So if you have a type 2 diabetic with high hemoglobin A1C, but is on the thinner side or has involuntary weight loss, I would definitely work with an endocrinologist, because the risk of ketoacidosis goes up.
Okay, I encourage everybody to raise their hands, ask questions. But in the meantime, Bert Anderson is asking, we are eagerly waiting for health economy analysis, especially in the context of FPEF. When we can see such papers?
Yeah, so I don't know. I'm not an expert in sort of health economics, but I do know that it's really complicated for two reasons. One is that the health economic equation is different in different countries. So there is no sort of global standard per se. So it depends on your country and the local market. That's one thing. And then the second thing is that it also changes with time, because the drug pricing and the the availability of generics change over time. So your cost effectiveness equation changes sort of dramatically. So I don't know the answer to that question, but I just want to put this in perspective that there are these nuances related to that.
Yeah, well, both for both of you, for Javed, also for Shelley, there's a question from Massis Perk. The question is, do SGLT2 inhibitors make loop diuretic less necessary or unnecessary in the long-term management of heart failure?
Shelley, do you want to go first?
Javed, you go ahead. I think you've been part of this analysis, actually, right? The publication.
Yeah, so a couple of things related to diuretics. So first, about 20% or so of the patients were not on diuretics. So there is a notion out there that SGLT2 inhibitors are nothing but basically diuretics. But the benefit seen, and we presented these data recently, and hopefully will be published soon, that the baseline use of loop diuretics or not use of loop diuretic is not a predictor of benefit from SGLT2 inhibitors, and those not on loop diuretics still benefited. So certainly there's something more than just being a diuretic. Now, in terms of what to do with the diuretic therapy, so in the clinical trials, there was no protocol to decrease the dose of diuretic when SGLT2 inhibitors are initiated. So despite of that, there was no sort of safety concern, and it was left to the clinician. Having said that, I think it's a reasonable thing that we should individualize our therapies because ARNIs have diuretic properties, SGLT2 inhibitors have diuretic properties, MRAs at the dose that we give, 25 to 50 milligram, we know are not really natriuretic. If you're giving it to a cirrhotic patient, you usually use high doses, 100, 200 milligrams. But that is when you use spironolactone alone. What is the renal effect of 25, 50 milligram in the absence of in the presence of SGLT2 or ARNI? I don't know. So I think we are hitting the diuretic properties from multiple pathways. And I think being a little bit cautious in older patients, those patients who are already on the lower side of blood pressure is reasonable, either for a close follow-up, or if you choose to proactively cut down the dose of loop diuretic by half or something like that, then close follow-up. I think it's a pretty reasonable thing to do.
I would just add from a real life standpoint, most patients I do no diuretic adjustment on. It's really those on the lower doses of diuretic. And again, it's about individualizing for each patient, those frailer patients, those who have a tendency to hypovolemia, that's where you would cut your diuretic in half, particularly those, for instance, on furosemide, 40 milligrams once a day. I'd probably at least cut it in half or even hold it in some patients.
So to Shelley's point, not to anybody's surprise, this is exactly what we showed, that in the clinical trials with SGLT2 inhibitors, the new use of diuretics or the up titration of diuretics was less in the SGLT2 arm, and down titration and discontinuation was more, which is sort of common sense to what Shelley's saying as well.
There's a raised hand from John Cleland. John?
Hi, so thank you for sharing, Javed, and thank you for your loyal service on the clinical trials group within the European Heart Journal editor team. I got many questions, and I'm not sure how many I'll have the opportunity to ask you this afternoon. But I guess the first one is, if we had a young European ESC fellow and he was thinking of going, or she was thinking of going to the States, which of the places that you've worked at would you recommend them to go?
All of them. Pick one.
Okay, well, that was very quick. So then we'll move on to the others. Do you think that...
I'm told this is being recorded, so I'm not going to take one name.
Yeah. So do you think that the introduction of cardiac myosin inhibitors, beg your pardon, like mavacamten, are going to actually make the case for heart failure with a supranormal ejection fraction? Because if we have a therapeutic for a specific phenotype, does that mean that we have to change?
But that's a really complicated question because we don't have too much data on that. So first, yes, these drugs do lower the ejection fraction, as one might expect. But lowering of ejection fraction as part of the therapeutic pathway may or may not have the same implications or concerns. For instance, with omecamtiv mecarbil, you got a little bit of a troponin leak, but you don't see sort of adverse effects per se. So I don't know what that signal means. The reason I specifically start with this answer, John, is because maybe those drugs may be beneficial not only on supernormal ejection fraction, but even not supernormal ejection fraction, but HFpEF like 50, 55. And if the EF drops by 3-4%, they may still benefit those patients for sure. So I think that it makes a lot of sense to study in HFpEF both normal but not supernormal and supernormal ejection fraction these drugs, and hopefully that will be.
Yeah, well, they have improved exercise capacity and dropped natriuretic peptides, so they do look very promising for that supranormal ejection fraction. But I agree with you. So I guess the next question is a bit trickier, though. So in the European Union, we now have 80 million population who have available to them voluntary euthanasia. So that means a doctor can give an injection which will terminate the patient's life. And indeed, if you have a university education in Belgium, it's a 1 in 8 chance you will die by injection now. So I was just wondering, in the States, you have assisted suicide, but you don't have voluntary euthanasia. But I just wonder, where are we hitting the end of the road when it comes to end-stage heart failure? And should we be kinder to our patients and fight for this option at the end?
Yeah, so this obviously is sort of a question where all of us will have our own sort of personal views. So I have not studied this question any formally. So my question is, my response is just me as a human being or as a physician who's taking care of a lot of these patients. So first, if you ask patients in the outpatient setting, there are all of these time trade-off studies that people say, oh, well, I would, give up this percentage of my life to, feel better and all that kind of stuff. But when they really get sick and they're really facing it, everybody wants to live longer. There are very few people. Now, cancer is different because you're in constant pain. But in the absence of that, so I think people want to live longer. Now, I lean towards more libertarian views, and I think that people should be free to choose what they want and what they don't want. But here's the trick, and the reason why I am a little bit uncomfortable in this particular case is that we do know a pretty significant link between depression and heart failure. And when people want to end their life, I just want to make sure that this is a sensible decision and this is not a reflection of undiagnosed underlying depression. And if they were to be treated, that they would feel differently. So I think this is highly personal. I would minimize and not encourage it. And I would definitely make sure that the person is comprehensively treated.
Wow.
And can I just add to that too, John? Very interesting question. And so as people get more advanced heart failure symptoms, polypharmacy may very well become an issue. And in that case, we have such great data with improvements in functional status and quality of life with use of SGLT2 inhibitors, that would be potentially one therapy that I would continue on because it's so well tolerated. It's once a day as well. And so if that provided some improvement in quality of life, I think that kind of therapy is willing to continue. But it's really important to have these discussions with your patients and shared decision making. And having medical assistance in dying in Canada, we have used that in some select patients as well, based on their preferences and their symptom burden that was not reversible at that time.
Well, we have many questions on the queue, so I will try to, summarize, and maybe we need short answers as well, but so we can answer everybody. But the first one is from Dr. Jingui Ren. And you probably already addressed this because he's asking whether we should pay attention to heart failure with supernormal ejection fraction and whether SGLT2 have effects on this kind or phenotype of heart failure. So I don't know if you want to add anything.
Short answer, until more data comes out, the answer is yes, and we should treat them.
Yeah, well, the question from Dr. Charbel Noujaim is whether the potential of using SGLT2 inhibitors in the management of atrial fibrillation and atrial myopathy looking at the current encouraging findings from preclinical studies?
So there are some data about a beneficial effect both on diastology and on the left atrial remodeling, but not clinical data that it significantly impacts atrial fibrillation natural history to my knowledge, and there are no trials in atrial fibrillation. So I would definitely treat it in heart failure patients with or without atrial fibrillation, but I don't think that we can have a leap of faith that this is a therapy for atrial fibrillation.
Here's from Flora Sam. Hi, Javed. Thanks for pointing out that a levodopa rejection fraction is important. Many folks say that findings from SGLT2 indicate that ejection fraction is not important when looking for therapy in HF. I would suggest that the beneficial are less dependent on the heart and that it affects are on the metabolic milieu. So there are two questions here. One, giving dignity again to ejection fraction, and the second, whether you think that the main effect is on the metabolic milieu.
Yeah, so when it comes to HFrEF, I think all of us would agree that the primary problem is with the heart, and then you have a whole bunch of systemic manifestation of that primary problem of the heart, no matter what the cause for the reduction in systolic function was. Now with HFpEF, there's a huge debate out there, right? So there are folks who very strongly believe that unlike HFrEF, which is a disease of the heart where systemic involvement occurs, HFpEF is a systemic disease where heart is involved as a sort of a bystander per se. And others would disagree with that. And I think this whole cardiometabolic milieu would force us to think more that it's a systemic disease. Part of the problem that we don't have the answer to this question is that we don't really have large-scale studies with human biopsies and HFpEF. So we are basically learning physiology from the systemic effects and looking at gene expression from mononuclear cells. And then there's always this question about what came first and what came second. But again, if we have this talk in 5 years, we actually may have an answer, because there's this large NIH program that has recently started called HeartShare, where there will be a lot of patients with HFpEF that will actually get research biopsies and that we will look at what's actually happening in the heart. So periphery and metabolism is definitely involved, but the answer whether heart is primarily involved or not, I think we will need to study the heart a little bit more before we know for sure.
Let me ask a telegraphic question to Carlo as a pharmacologist, and then to Javed and Shelley. The dosage of dapagliflozin and empagliflozin was based on the studies in diabetes. So it was let's say a hypoglycemic dose, or an attempt to control better diabetes with that dosage, and that was transferred to heart failure. Do you think should we explore further what is the dosage in heart failure, or that's enough? Carlo, the microphone.
Typically, pharmaceutical companies spend very little time in phase 2. They don't want to spend much time doing those finding studies, but I think these are very important, particularly when you change the patient target. And so more studies along those lines would be interesting, particularly if you think that the target population is somewhat different than the originally studied patient.
Shelley, are you satisfied with the dosages, or?
I think so, and I believe EMPA-REG explored 25 milligrams and 10 milligrams, and so I think I'm pretty satisfied. We have pretty robust and profound clinical trial data with the 10 milligram dose, and it simplifies things for me as well. But both drugs have a 10 milligram dose, so it's easy.
Javed, anything else?
No, not much to add, but I want to highlight the question in the opposite way, that actually we don't know the answer. So we do know that 10 milligrams work. Canagliflozin 100, 300 milligrams, and empagliflozin 10, 25 milligram really had no difference in terms of the cardiovascular outcomes in diabetes patients. Whether in heart failure patients, higher dose would benefit more or will just have more side effects, I have no idea. but 10 milligram for sure works. And I think that's the evidence we have.
And when 10 and 25 work the same, that means we are at the top of the dose response curve, and maybe lower doses might be also as effective. Or...
Yeah, there's a question. There was a question because there are so many that I lost it now on the chat. But the question was about the right heart failure, whether there is anything ongoing or that has been done with the SGLT2 inhibitors on right heart failure.
Not to my knowledge. There was a study done on individuals with CardioMEMS device to look at pulmonary pressures. Small study, about 65 patients or so, and that did show that the use of empagliflozin was associated with a reduction in PA diastolic pressure. The benefit was seen actually quite early between the two, placebo versus empagliflozin, at about 1 week. And curiously enough, and please don't quote me on that, I don't totally recall that paper, but I think it was a 6 weeks or 8 week study. But even they followed the patient for safety a week after the drugs were discontinued, and there was still persistent further decline in PA diastolic pressure. So they certainly have impact on pulmonary hemodynamics, but how much does that impact on the RV side for RV failure? I don't know of any data, but maybe somebody else does.
Now let me switch to the EIC. Filippo, you have a raised hand?
Yes, well, Javed, thank you first for the time you are dedicating to this dialogue and to the European Heart Journal as associate editor. It is really a fascinating class of drug because we can identify cardioprotective effects, nephroprotective effects, and then it started as anti-diabetic treatment. And recently, we've shown an experimental model of FPF vascular protective effect on coronary microcirculation. Do you think it is possible that these different effects are mediated by different mechanisms? For instance, in the proteomic study you showed before, you found nephroprotective and cardioprotective effects mediated more or less by the same proteins profile. Then we have anti-diabetic effects, which might be more related directly to SGLT2 inhibition. And then we have vascular effects, positive vascular effects, which might be mediated by an anti-inflammatory treatment, by an anti-inflammatory effect. So perhaps it's really a broad range of positive effects mediated by different mechanisms. Coming to the experimental model published in Circulation, for instance, you say knockout for SGLT2 didn't prevent the beneficial effects of gliflozin, but which effects? Cardioprotective, nephroprotective, anti-diabetic, or vascular effects?
Yeah, so I mean, I would not know how to answer that question because, again, the biology is so complicated and interdigitated that you don't know what is first and what is second, right? So you have some reduction in visceral adiposity, so you have some decrease in inflammatory and oxidative stress burden, and that in itself then have secondary benefits, which may not be the pathways directly affected by SGLT2 inhibitors. And then there are other pathways that are directly affected by SGLT2 inhibitors as well. The study that you mentioned, they looked at the infarct size in a mouse model of creating ligation and infarct. And the infarct size was equally protected in both knockout model and wild type with the use of empagliflozin. So at least we know for the heart. I would assume that there are probably some other proteins that are involved in the renal mechanism and not the same ones, but I don't know.
One related question, then I will shut up. We recently published an interesting viewpoint by Marco Metra proposing that SGLT1 inhibition might have additional beneficial effects. Do you agree with him?
Yeah, so this is the little sort of frustration that sometimes really important questions are very difficult to answer because the clinical trial enterprise is very expensive. And hopefully we will move to this era of pragmatic and decentralized trials where we can do the trials relatively cheaply. So if you look at the data with sotagliflozin in the SCORED and the SOLOIST trial, it's not the cardiorenal benefit. I think that are very comparable to SGLT2 inhibitors in terms of the myopathy, heart failure, and renal protection. But in terms of the vascular benefit, especially the stroke benefit, that certainly seems to be much more than what we have seen with SGLT2 inhibitor, which really raises the question whether SGLT1, SGLT2 combined inhibitors will have more vascular benefit than what we have seen with SGLT2 inhibitors. But in the absence of the trial, I don't know how to answer that question. But I think both Marco and Bert Pitt have written a lot about it, and this question is really worth trying. And I do know several investigators in different countries are approaching their federal funding agencies to do a trial like that.
There's a question from one of my former fellows who's today a pediatrician, a pediatric cardiologist, and he's asking about cardiorenal syndrome, whether there is any studies on that. But I would like to add to this whether there are studies in children, as you may know, as you Javed or Shelley.
So I would not know how to define cardiorenal syndrome and what exactly is the entity. We do know that at least with EMPA, we went down to GFR of 20, and with DAPA-CKD, GFR of 25. So people with combined cardiovascular risk factors or manifest cardiovascular disease and really low GFR, these drugs have been safe and in those subgroups effective and beneficial. So if, when people do all sorts of renal, cardiac, and cardiorenal and what came first, and I sort of find most of the time those definitions somewhat arbitrary because again, we just really don't know which is causing what. But certainly combined renal disease and cardiac disease, these drugs work for sure. I don't know much about the pediatric literature or whether there is any trial going on. I don't know that.
Yeah, I think the MPulse study probably most likely or represented cardiorenal syndrome. They had a lot of patients with CKD, and the effect was present, regardless of EF and regardless of EGFR cutoff. So I think the MPulse data probably represents that patient population the best.
Giovanna, I'm sure you have another tricky question for Javed.
I was just, thinking to all of the things that we have listened this afternoon, and I have a question. Do you think that we have scratched at the bottom with the treatment of heart failure? Because we have a treatment for all the range of the ejection fraction. We have included almost all the possible subgroups of patients. So we don't need any more. Or do you think there is still room for other drugs, for other devices, for the other studies that can fill eventually, left gap in the knowledge?
So I don't know the second answer, which is how we will do it, but I know the first answer, and that we definitely need more therapies. And the reason why I say that is that if you look at, for instance, DAPA-HF, right? So DAPA-HF is one of the lowest risk populations we have recently studied. We had 70-75% class 2 all outpatient and on excellent baseline therapy, about 90% RAS inhibitor beta blocker use and about 70% MRA use. And by definition, 100% SGLT2 inhibitor use in the dapagliflozin arm. And then if you look at the New England Journal paper, the area under the curve, you're still talking about with quadruple therapy in a somewhat of an outpatient, lower risk, and an annualized event rate of heart failure and mortality ranging about 13.6% or something like that. And then in Emperor Reduce, we tweaked it just a tad bit. I mean, again, outpatient, very well treated, not recently hospitalized. But the only thing we did was we went from GFR of 30 to 20 and a little bit higher natriuretic peptide and raised the risk by 40% in that patient population. So there's substantial residual risk that we definitely need more therapies. Now, how are we going to evaluate and give 5-6 therapies? That's a whole sort of a separate debate. But I don't think we are done with our work completely. And then in HFpEF, we really haven't conclusively proven with any therapy reduction in mortality, only hospitalization rate. So yes, we have a lot more to do.
We're aiming towards the end of this extraordinary hour, but I see that Carlo has another question. So it's
yeah. Well, so Javed, what are the missing pieces to complete the SGLT2 puzzle?
Yeah, so many missing pieces, right? So downstream, we have figured it out. So we have HFrEF, HFpEF, acute heart failure. So we have studies there. Then a little bit upstream, post-MI, in the next year or so, we will have the data. A little bit more upstream is type 2 diabetes at high risk and prevention of heart failure, and we have definitive data. So where we could use more data is non-diabetic high-risk patients. We have some data with CKD non-diabetic population. We probably could have more or other high-risk features. But I'm not too optimistic that those kind of trials will occur because of the size of the trial and the duration of follow-up that is needed. But then there are all these niche populations, right? So John was talking about hypertrophic cardiomyopathy. So, whether these drugs work in patients with hypertrophic cardiomyopathy, there is a lot of ventricular dysfunction that is occurring in post-valvular intervention patients, right? So we have these TAVR patients and all those that we have now interventions, but how to change their ventricular sort of journey, we don't know. So lots of interest whether giving these agents in post-valvular intervention patients would be of benefit, amyloidosis and other subgroups. So I think that these smaller niche populations, cardio-oncology and with chemotherapy, can you prevent LV dysfunction? So I think in these subgroups, we will probably get more data, but true primary prevention, probably not. But yes, we have a lot of data, but we could use some more.
Thank you.
A medical student said in the chat that this was a glorious day. So it's been a very good time. But there's a question that I'd like to ask you that puts together many questions that were on the chat. So what's missing in the discoveries to be done in heart failure? Now we have several types of drugs, several types of device intervention. We can use, personalized therapies in a certain way to many patients, but still, hospitalizations are pretty high and mortality remains higher than expected a few years ago with all these compounds, and especially now with these additional benefit of SGLT2 inhibitors. So what is your opinion?
Yeah, I would say that there are 3 or 4 different directions where science will continue to move. So one is obviously more therapies, more effective therapies to further reduce mortality and hospitalizations rate. As I mentioned, we are nowhere close to being done. These patients, even on those 4 foundational therapies, have substantial risk. So that's one. The second is the promise of personalized medicine in the omics era right now. So at some point, hopefully in the future, we will be smart enough that we will figure out which combination to give to which patient, but we are not there just quite yet. The third thing is that it's not always escalation of therapy, but de-escalation of therapy as well. So, John and I have talked about this quite a lot, whether it's time to retest the use of ICDs in primary prevention, because all of these therapies are reducing certain cardiac death, and that landscape has changed. So maybe we don't need it, especially non-ischemic cardiomyopathy. And then the fourth thing is implementation science, right? How are we going to achieve all this? So maybe the future is, a poly pill and just be content with low doses and give encapsulated pills so that you can improve adherence and compliance and give it to the population at large more frequently. So I think between more therapy, escalation of therapy, implementation, personalization, and de-escalation in certain specific therapies, it'll be fun next decade.
Shelley, anything to add? What's your wish? And
I think my wish is implementation for sure. I think that's our biggest challenge. We've had some really important clinical trials like STRONG-HF show us that it can be done. Achieving full doses rapidly in our patients to maximize and reduce their residual risk. So implementation is the key, I think.
Filippo, there's work also for you because there's Abdelaziz promising to submit a paper on this to European Heart Journal. So we have work for you coming. Anyway, I think we completed our hour more or less, but if there is any final comment or questions, we'll be happy. So Amelia is saying that she's happy. So we're all happy. So,
I can make a final comment at the end of this very interesting hour. Well, this is really a huge chapter and exciting story. So thank you, Javed. And I think a lot remains to be discussed. For instance, the beneficial effect on hyperkalemia, the beneficial effect on uric acid. I mean, really, you have opened a window, you, Javed, main protagonist of this fascinating story. You have opened a new window, which is really incredible. And so many things are emerging. So I think that we will need another dialogue to expand what we have discussed today. For the time being, thank you, Javed, Carlo, Shelley, Massimo, and Giovanna for this wonderful hour. And let me announce the next dialogue, which will be on Thursday, February 23rd at 17 CET. And will be with Josip Brugada, will be the Brugada syndrome narrated by Josip Brugada. I'm sure will be a fascinating story. So thank you for your participation and see you on the 23rd of February at 17 CET. Bye-bye.
thank you very much, Javed and Shelley. Yeah.
Thank you.
Thank you.
Thank you.
Bye-bye.